Thank you very much for the introduction, Carlo, and thank you, Andrea, for inviting me today to give a topic which is perhaps fitting into this rhythm discussions today, but it comes in from the cardiomyopathy and from the genetics part. So just one thing that I have to make clear, because we're going to come back to that at the end, is that we've moved from single gene to multiple gene analysis. So nowadays, when we have a patient with a diagnosis in cardiology, usually between 50 and 200 genes are looked at as in one process. So we call this a gene panel. And there are, of course, more genes for certain of the genes. They're the ones that are more frequent, but there is also the interest in research, and therefore that's why the cardiologists are always asking for some rare genes to be on our panels. And what is being carried out nowadays is what we call an exome analysis, and the exomes are spaced with introns between them, and we only at present looking at exomes. So this is the part of the analysis that's being done. And so therefore, if you remember your biology from a while back, we go from the DNA up here with the exon and intron going to the RNA, going through to the messenger RNA where the splicing has occurred and the exomes have been cut out. And from there you go to the chain of amino acids. Some of them get modified afterwards, and in cardiology, most of them not, except if we were looking at metabolic things and things like that. And so today we are missing everything that's in the intron, and that will come later when the full genome is looked at. And that most of the labs in Belgium now are able to carry it out, but it's not yet being reimbursed, so therefore it's not being done in the diagnostic as yet. So not only has the technology advanced, but also the classification, and the word mutation has been dropped the last 5 years. And the reporting now has become much more accurate by giving a class. And we saw that the patient of Kauro here had a class 5 variant. And so that is a pathogen mutation, which means that it has more than 99% chance of being pathogenic. And these are ones where functional studies have been done, and there are multiple families to be able to be a class 5 variant. So the variant classification nowadays is complex, but it's divided into 5 classes, and the class 1 is the benign one. And our DNA varies, 10% of our DNA varies without causing any problems as far as we know. And these are all the benign, what we used to call polymorphisms. 2, 3, 4% of patients have at a specific position a certain variant which does not cause any pathology. So the ones that interest us here are the ones that are pathogenic or likely pathogenic, or the unknown, those with unknown significance, but where there is something that's indicating that it should be going towards pathogenic. So these are the ones that are being reported and are actionable, and therefore the class 1 and 2 are never put onto a report. So those who are in research like to see those. They are all available in the laboratories, but it will not come onto your report and come out to you. I'm not going to go into this complex slide. The clinical laboratory geneticists are people with doctorates and a lot of experience and expertise, and there's a whole list of criteria that they use in working out which class it fits in, and they have access to multiple databases and literature in order to get this sorted out. And we know that we don't find a variant in every patient. The highest yield, of course, is where you have a positive family history. And we also know that we don't know all the genes because of the 20,000 genes that we expect to have in each of our cells in the body. Only 8,000 have been attributed to one or other disorder. So there's more than half the genes that are not yet attributed to a condition. We all think we've got the most important genes, but there may be 1 or 2 more that come through. And we are only sequencing these genes, and there are many other types of things that are also important, not only the sequencing of a gene, but methylation and all sorts of other things that will go around it. So we don't detect all the variants at the moment, and the penetrance, when we look at also the clinical part of it, mostly of our families that we are seeing in the diagnostics, the pure cardiology, not the metabolic and the complex syndromal ones, are autosomal dominant in inheritance. And when we're looking at that, we know that sometimes the penetrance is not full penetrance when you do the family tree. We're always trying to get at least a 3-generation family tree. And you see that this person here is an obligate carrier of the variant, but he's not expressing it. Now, it's important also to know when you are examining this, doing this family tree, if you're doing it a clinical picture, that age is important, because we know that many of these disorders only present at adult age or even after 30 or 40. So your penetrance varies depending how you've looked at the age, and also males and females we know express at different times. The expression is very variable, and the isolated cases are it's recommended that we look at them as well, because there's such a thing called de novo, which means that both parents are not carrying the variant and the person comes out. And that's less than 1% of all cases, but we still get them every year, 1 or 2 in the laboratories if we have a big turnover. So these are coming. And then interesting thing in the families is where we have worked out who's carrying the mutation. If we say the C is the variant, the pathogenic variant, you see that this patient, let's say here with an A and A, is not carrying the variant and therefore should not get the disorder, but has expressed it as well. So these are what we're calling phenocopies. There may be another reason for that person in the family to have the condition, and it's not part of what you're having. So, as you know, the new cardiomyopathy guidelines from the ESC came out earlier this year, and therefore I'm using some of them because this is open access to everybody to look at it. So the patients are coming in towards genetic start at the top here, and it's patients that present with you either with symptoms, or if he's coming to have a knee surgery or something else and they do an ECG and there's something that gets picked up along the way, so it's an incidental finding. All the ones that feed into us are the ones that have already had the genetics in one or other family member, and the other family members come along, what we call cascade testing, children, brothers and sisters, parents, etc. And this we're very active. So if we just go through here, these go through all the functional characterization, morphological, the ECG, echography, coronography, and MRI when necessary. And it comes down here to the geneticist, and we work extremely closely in UZ Brussels with our cardiologists, and pedigree analysis and the genetic testing gets carried out after a discussion with the clinical geneticist. So this is the pathway that our patients are taking at the moment. Now, if we take the third branch of that, and we have in the family found either a pathogenic or a likely pathogenic variant, then we asked to see the other family members, and therefore they get tested, and those that are carrying are followed up, and those that are not carrying get discharged from the whole process. If we have a class 3, which is an unknown significance, but one that we think could really probably be more important, we do what we call segregation analysis. We try and look both in a cardiology aspect, but from the genetic aspect as well, see who are carrying and who are not carrying the variant, and does it match with the clinical pictures in the family. So this also goes down a regular whole process. Where we do have a variant of unknown significance and segregation has not helped us, or where there's been no variant found today, these patients are called back regularly 5 years later. So plus minus 5 years. So technology advances and more genes are known. So it's important to keep them on your books. And what I would like to come to today, because we are discussing ventricular tachyarrhythmias and other things, and here we have use the DCM and the non-dilated left ventricular cardiomyopathy group. These are two groupings of cardiomyopathies, and we see here that patients come through and are labeled with a high-risk gene. It's not a high-risk gene, but it's a type of variant that is in that gene that makes it a high-risk gene, and therefore these high-risk genes is what I would like to bring out here. And if we look at which are the genes that come out here, these are one of the nuclear genes, the lamin A, and it's certain variants, and it's a non-missense variance, and that I'm going to discuss with you, because if you have a missense variation in that gene, it does not put you in a high-risk category. You need to have everything except the missense. And same thing with the FLNC. Only the truncating variants are the ones that are important. The ones that just have a missense and things are of less importance or at this stage. It's a bit the same thing in those of you who know titin, that big gene. Only the truncating mutation or variants are reported, and the laboratory already screens out the missense ones unless it's part of a research, but in the diagnostics we can do nothing with the missense at the moment. So it's very important not only to know which gene it is, but also what kind of mutation you're getting. And therefore that's why I wanted to show you one or two things. What is a missense? If we have here the DNA with the codons, which are read 3 by 3 to produce the amino acid that you're seeing, met, glycine, lysine, tyrosine, etc. And you look at 3 by 3, and if here we have an AAA, which codes for a lysine, and you get a variant coming out as ATA, this is a missense. It means just one letter has changed, and you're changing the amino acids, because now you're getting a different amino acid coming out, but the rest keeps going on. So it's a change of in one position of one of the letters of the DNA. And this is it's not important for laminopathies, and it's not important for LFL and C, where these are your high risk for rhythm problems. However, if we look at this TAT here, and we change it to TAA, this is a stop codon, and therefore what's going to happen is that the reading stops here, and the amino acid chain will be much shorter because it's stopped here and hasn't gone on to have the rest of the DNA read. So this is a stop codon, and what we call it truncating. It's cut it off. So the protein is much shorter, and therefore that will probably be degraded and not function at all. Or if it's still whole, the small protein remnant stays, it can cause more trouble than them not being there. In the same way, for laminopathies, not only do you want it to be either a nonsense truncating, or it can be an insertion. Insertion means that we have the normal code and we put in one or two letters. So here we put in AAA, and that what it does here, it's 3 nucleotides insertion, and therefore the rest of the read looks the same, and it stops here. So you have one amino acid in here, but it changes the protein. So that is an insertion, is also one of those 4 laminopathies that interest you. And the third is, but here I've shown you 3 nucleotide insertions. If you have 2 or 1 insertion, it shifts the rest of your reading, and the rest is no good. So it's a bit like when we have a deletion of one of these. If we have here ATG and then here GGA, and it's changed to a C, and the C is deleted. It's taken out of the whole code. Then everything changes here. If you look at the amino acids that are being produced here, you see that these 2 first ones are well, and then the rest, everything has shifted to the left, because there's one being taken out. And by shifting it, when you're reading them 3 by 3, all the rest of the code after these first 2, all this is wrong. But not only is it shifted, but sometimes there can be a stop. One of these read as a stop earlier or later. So frame shift variants due to deletions or insertions, and nonsense variants. All these here, when they're in class 4 or 5, are high-risk laminopathy, causing 5 to 10% annual risk of arrhythmia. So this is and then that was the same issue with the filament C. They need to have a truncating. It's where the protein or the amino acid chain is shorter. When you truncate something, you cut the rest off. So these are the different interpretations that get done by the scientists in the laboratories, and the team we have are excellent in doing this. So as you see in your risk calculator, those of you who use this laminopathy risk calculator, the ventricular tachyarrhythmia calculator, you see that the two first aspects are the sex, and then secondly, the non-missense LMNA variant, we would call it nowadays. Right, so that is important that these are this be filled in, because that changes your percentage. It's one of the strong factors in this whole equation to get you a positive, a significant risk factor. So I think all this work that's being done in the genetic laboratories and at the clinic, the genetics clinic, is part of a multidisciplinary team. And in UZ Brussels, we meet once a week between the cardiologists, representative both from cardiomyopathy and from rhythm clinics, together with the clinical geneticists and the clinical laboratory geneticists, and this team here, together with the coordinators or specialist nurses. And this makes that things go smoothly and we can advance quickly and accurately and in a professional way, and have a link back to academia where necessary. So the team that we have at the moment, we have these three scientists who are excellent. And this one, Philippe here, has unfortunately now been made head. Well, fortunately for our department, he's now head of the laboratory since which we desperately needed. And since he's taken over, things are moving in the right direction. And the service, we hope, is getting better and better. Esther Skierlink is joining our clinical team on a part-time basis soon. And so we need to keep growing. And all this is under the guidance of Friedrich Hess, who's been working on moving the department in the last 5 years. So, can't talk about genetics and without the future. Was even in your program, your last presentations today are of the future. And we know that we've already seen that in different things, like in the HOCM, there has been a medication which has come in now, which works specifically by binding on the actin. And we know that in hypertrophic cardiomyopathies, MYH7 and MYBPC3, the myosin binding protein, C3, are important. They're the sarcomeric genes, and mutations or pathogenic variants in those account for at least 70% of these cases. And what happens there is that you get the balance between the actin and myosin gets disturbed. And that's how now, with having an actin inhibitor on the market and being used in Belgium this year, you get your medication that's come in to bring down this contractility, to help to bring down the gradient of the left ventricular outflow tract. And this has been used in our hospital. At the genetic level, protein level, first of all, the amyloidosis, which causes cardiomyopathy, the TTR is as a tetramer. And what happens is that when it gets broken down, these infiltrate in all the parts of the body, and all the therapy that's being used now is a stabilizer to keep this as a tetramer, to stop the infiltration with time. And the one that's become the patients like the most is the ones with hypercholesterolemia, because if we look at LDLR, that's a low-density lipoprotein receptor. Very important in the last few years that there has been, if we look at how the treatment is done now, if we go from DNA to RNA, when we get to the messenger RNA, nowadays we have what we call small interfering RNA molecules, which come in and bind for the PCSK9 RNA. It binds and blocks the functioning of this PCSK9, which is vitally important, first of all, for bringing the low-density lipoprotein to the receptor on the cell surface of the liver cells, and also for its production. So the synthesis of the PCSK9 is blocked. There is also a second type of treatment, which is the antibodies, which capture the PCSK9 in the blood, but this needs a therapy every month, whereas the other one, the small interfering RNA, they get a subcutaneous injection once every 6 months. In the beginning, for the loading, they do 3 months, once 3 months, and then thereafter it's every 6 months. So the patients are always very happy that they only have to have a subcutaneous thing every 6 months to keep their cholesterol, and the cholesterol drops rapidly and to much below the normal levels. So this is where we think we're going to get more and more and more of these coming onto the market. We know that there are plenty in the guideline. If we know more and more about the structure and function of all these molecules, we can get to the answers. So we're hoping that it's going to be a lot more breakthroughs. So that's my presentation. Thank you.
Thank you very much.